All right, this is part 2 of chapter 11. We're going to pick up on slide 19 with opportunistic infections, and you have a great table on page 226, table 11.5, that talks about organisms of disease and opportunistic infections. And we're not just thinking about opportunistic infections with just HIV, although that's what we're talking about right now. We really want to think about these opportunistic infections with anybody with a very compromised immune system. So these people, again, to reiterate from the last slides from the last chapter or the last slides about people who are just immunocompromised, we really want to keep them away from those fresh fruits and vegetables and the fresh flowers, because there could be bacteria on them. Make sure their foods are fully cooked. They're not digging around in soil, because there's lots of bacteria found in soil. They're not messing with lots of different animals, especially things like birds, because we can get things like histoplasmosis. Toxoplasmosis is another one that people usually find in cat feces and cleaning out litter boxes. So just take a look into those opportunistic infections. There's actually quite a few slides here. Just going to leave that one up to you. Varicella, of course, is chickenpox/shingles. That's the zoster virus, so that would be shingles. Cytomegalovirus is a type of herpes. Herpes simplex 1 and simplex 2, that is oral and genital, of course, herpes. Those bacterial infections, you see the Mycobacterium avium there. The next slide, on slide 20, is more opportunistic infections. Those fungal infections, I really want you to pay a great deal of attention to candidiasis, that is yeast. Yeast is something that we get quite frequently inside the mouth of people who are immunocompromised, because their own normal flora kind of take over when our immune system goes down. It's unfortunate, but our own flora can do that to us. Let's see here. Let's go to the next slide. Other complications of HIV and AIDS, we've already talked about Kaposi sarcoma and lymphomas. Lymphomas are overgrown tissue that you'll find in the lymph system, usually in the lymph nodes. And we'll talk more about those in just a little bit. Wasting syndrome is very particular. We see wasting syndrome with people who have lost a certain amount of body weight and keep usually diarrhea. Let's see what your book says. Wasting syndrome is defined as losing more than 10% of weight, along with at least 30 days of either diarrhea or weakness accompanied by a fever. So that is very particular for wasting syndrome. But if you've ever watched the movie Philadelphia, you'll see what wasting syndrome and Kaposi sarcoma look like. It's a fantastic movie with Tom Hanks in it. You should watch it. Neurological complications, that is in your book on page 222. Hang on, I'm looking. 227 it looks like. And the neural complications can come from a variety of different things. It could be just the progression of the virus itself. It could be opportunistic infections that's invaded the brain tissue. And then you can have neurological complications from the medications as well. So you might see things like depression, shaking, forgetfulness, things like that. We're going to skip the questions on 22 and go to assessment and data collection for our HIV/AIDS patients. A history and physical is very important. These are important for anybody's intake exam, but you definitely need to make sure you're talking about sexual history, history with unprotected sex, and of course, if they come back positive, we need to identify the people that need to be notified to get tested. Let's see here, what else? Sharing of needles or any kind of illicit drug use. Make sure when they have, and this was with anything, if they come in with complaints of a certain thing, make sure you're going to ask these questions on when did it start, what makes it better, what makes it worse, what are the symptoms of it. If you've got a cough, how long have you been coughing something up? You need to get really detailed so we can figure out exactly how to treat it. And that would be your focused assessment. So if someone came in and say, I keep getting sick all the time, I don't know why, I keep getting thrush in my mouth, or thrush, of course, is yeast, then we need to be asking those very in-depth questions on when did it start, how long have you noticed it, what makes it worse, things like that. Psychosocial history is also very important for these patients because it is a depressive, can send them into a depressive state because it is a diagnosis that never goes away. So I definitely want to make sure that those people are still keeping in contact with friends. They're still able to, they're still motivated to get up and do things and work and lead a normal life. They just have to be able to understand that taking medication is just a part of what they do now. That might not just be help from you. They may need to see a counselor or a psychologist or a psychiatrist or something along those lines. But I need to make sure that I'm looking at their psychosocial history. How have they acted before? Is this going to change anything? You can find those things. The most important, I think, on 227 is the focused assessment data collection for patients with HIV. I've got a couple of things circled here I thought was important. Definitely assessing for visual changes, weight, always looking at the mouth because people with low immune systems have typically get that yeast or that thrush in their mouth. Determine the characteristic of any cough is very important. Look at their skin and mucous membranes. We're looking for Kaposi sarcomas or any kind of lymphomas. Determine any nausea, vomiting, or diarrhea that can help us determine the wasting syndrome. Just read through those things, okay? Those are pretty important for these people. Planning is the next one. We want to make sure that they don't get any secondary bacterial, viral, or fungal infections. Of course, their primary infection would be the HIV or AIDS. So we want to try to prevent them from getting into those opportunistic infections. And that means that we're going to teach them how to wash their hands, keep themselves clean, make sure they stay safe from any injuries, all those things that we think we need to tell them to help them achieve a healthier lifestyle. Their diet, their exercise, things of those matters. Prevent wasting caused by malnutrition, and this could be dietary counseling, making sure that they're getting enough protein. If they're having nausea and vomiting, medications that could stop that. If they're having diarrhea, medications that can help that. Maintain or improve the present level of immune function, and that's definitely taking their ART therapy, their large amounts of medicines. They need to make sure they take those appropriately and at least 90% of the time correctly. All right, they have to take them all the time, but if they don't take them at least 90% of the time correctly, then they don't work at all. So you definitely want to make sure that they're taking their medications appropriately. Make sure you're talking about their diet and their exercise again. It also talks about adequate social functioning, making sure they're still getting out into the community. It's a depressive matter anyway, but we don't want it to make it worse. We don't want them to seclude themselves from everyone. They just know, as long as they know how it's passed along and that they're not doing those things, we want them to get out there and have as much of a normal life as possible. And maintain or improve current mental status. And that could be, again, going to a counselor, seeing a therapist. That could be even antidepressants, anything along those lines. The next slide is implementation, teaching them all standard precautions, teaching us. We want to make sure we have standard precautions with everybody, of course. So everybody, this is for their household too, making sure the people who live in their household understand to wash their hands, don't touch any body fluids, and things should be just fine. Patient teaching is compromised immunity. They need to understand what that means, that they need to stay away from large crowds in like flu season, especially now they wouldn't want to go out. They want to make sure that, they're not being around anybody who's sick, that they're very prone to get sick themselves. Make sure they have good infection control in their homes. That means keep a clean environment. Make sure that there's no safety issues because we definitely wouldn't want them to fall and, hurt themselves because they're at a huge risk for infection as well. And then again, we're talking about wasting syndrome and nutrition. So lots of education about how to prevent those things. And nutrition, plenty of protein, of course, that's important. Could be involving medications to take before they eat to prevent nausea, whatever it may be. Evaluation, data collection, analysis at regular intervals. That means people need to come back in for checkups. They need to have their vital signs taken, weights done, things of that matter. See how they're doing with their medications, check their viral loads, do some blood work. Patients need to be actively participate in keeping journals of what they're doing, making sure they're taking their medications. Other than that, just monitoring your tests and making sure it says to look at your viral load and your blood cell status, looking at the CBC, all those things that could be indicative of a low immune system. We're going to be monitoring those tests on occasion to make sure that our counts start looking better. Other health issues, we don't think about it a lot, but there's a huge risk for HIV in people over 50. These people typically don't have to use any kind of protection for intercourse because they're not of childbearing age anymore. And sometimes they've lost their spouses and they're widowed or whatever it may be, and they're out, having a good time. So we definitely want to pay attention to that population as well. We want to make sure that we get education out into the community and that people have access to care. And, a lot of people who live in low socioeconomic places don't have that kind of access. So that's where our health departments become involved. So we need to make sure that the education's out there. HIV confidentiality and disclosure. There is some good ethical stuff in your book on page 230. So we want to make sure that I want you to read the legal and ethical considerations on that page for this. And it talks a little bit, ask a question about when a nurse has HIV. And honestly, that's an opinion. When a nurse has HIV, of course, they have to protect their patients from themselves. So, that's pretty easy to do, in my opinion. But patients, when they come into the hospital, they don't have to tell you if they have HIV. Even if they're like in labor and delivery or whatnot, that's their prerogative. Bloodborne pathogen exposure in healthcare workers. There's a few ways that you can be exposed to bloodborne pathogens as a nurse. That could be a large bore needle stick that you've already stuck the patient with, of course. That would be considered a pretty good exposure. If you've gotten blood or body fluids in a mucous membrane, say your eyes or your mouth. I've even had it go up my nose once, and that was considered an exposure. That's about all I can think of for exposure to healthcare workers. But when that happens, if you're stuck by a needle, you have to remember that the first thing you do is go to the sink and wash it very well with soap and water. All right. And then you have to tell your supervisor, and then you have to go get your testing done and all that stuff. So when you're exposed to someone that is positive for HIV or it's undetermined, your place of employment may say you can go ahead and take prophylactic antiretrovirals, and that will be your choice because it's not an automatic that you're going to get HIV. But most people, I think, if they have been stuck with a needle that they know that the patient has HIV, taking those prophylactic antiretrovirals would probably be a wise idea. They make you feel really bad, all right, but it's better than having HIV. They're very expensive, but your hospital should cover that under their insurance. So definitely something that I would do. Now, I've had exposures to people before that were undetermined if they had HIV, but it was like the blood up my nose, and I did not take the prophylaxis because that was a small risk. And then they did eventually do testing on myself and that patient, so we came back fine. Next slide is autoimmune disorders. There's tons of them. You have a very large table on 231. So I want you to get out and I want you to circle what we're about to say, because a lot of these they don't go over in the chapter, but I want you to be aware of them. The first one is autoimmune hemolytic anemia that affects your red blood cells. I want you to also circle rheumatoid arthritis. A lot of us have heard of RA, and you've seen the little ladies with their fingers all to the side because of the arthritic joints. This can affect your heart, lungs, joints, nerves, and skin. Systemic lupus, which we are going to talk about, can affect your brain, heart, lungs, kidneys, joints, blood cells, and skin. I want you to circle Addison's disease, which affects the adrenal glands. I want you to circle celiac disease, which affects the gastrointestinal tract. Those are the people who cannot eat gluten. On the next page, I want you to circle Crohn's disease, which is also a colon problem. People with Crohn's disease lose large portions of their digestive system of their colon because the body attacks itself and kills parts of the colon. Graves' disease is hyperthyroidism. I want you to circle that one. People who have hyperthyroidism are known to have like hypermetabolism. Guillain-Barré is a peripheral nervous system problem. And I want you to notice to the side, it causes ascending paralysis. And that means the paralysis starts in your toes and works its way up to you know, till it gets up here. Every patient I've ever seen with Guillain-Barré has gotten it because they've had a reaction they were allergic to a flu vaccine. At least most of them I've seen, I think. But you start getting tingling and numbness in your toes, and it works its way up to your legs and your bottom till it gets up to your chest, and you're unable to breathe and you're on a ventilator. Now, it goes away the same way it comes about. It goes away from top down, all right, little by little. Circle Hashimoto's, which is a type of hypothyroidism. So that would be hypo means I would have an under metabolism. Myasthenia gravis is a connection between the nerves and the muscles. These people have this weird mask-like feature about them, all right? And it doesn't say a lot about it, except it especially affects the eyes. But what we usually refer to these people as having a mask-like expression. Pernicious anemia is a problem with your B12, and I'm lacking in the intrinsic factor in the stomach. Raynaud's is another one that affects my fingers, toes, nose, and ears. That's a vascularity problem, so a lot of people can go outside. Their fingers will turn purple, and it's because they have a vascular problem anyway, and they stay cold a lot. There's numbness, tingling, and pain in their fingers and their nose. Anything that, you know, is an appendage that sticks out like this. And it's really triggered by changes in the temperature. So we really want to pay attention to that one. These people are recommended to stay bundled up and have layers on so they can take and put off what they need. Type 1 diabetes is a huge one to remember as being autoimmune. Remember, all these autoimmune diseases, their body's attacking themselves. So in type 1 diabetes, the body actually attacks the beta cells that help make the insulin, that do make the insulin. So my body cannot make insulin with type 1 or juvenile diabetes. And Sjogren's syndrome, I want you to also put on there, that affects the salivary glands, the lacrimal glands, joints. This is known as the drying disease. Everything gets very, very dry. My body attacks the cells that make these secretions. And I think that would be enough for that one. Okay. Those are good ones to know for the future. All right, next slide just talks about more of the 80 diseases. We talked a lot about those. Diagnosis on the next slide is, pretty complicated in most situations to diagnose an autoimmune disease. The diagnosis part's on 233, and we need, of course, get a health history. A lot of things, because they can mimic other disorders. Autoimmune diseases are a little bit hard to diagnose, so we're definitely going to do a health history and a complete exam to try to figure out what body parts are affected. And as you can see, a lot of these body parts are different, so that kind of leads us in the way that we should be testing it. And from there, we can do our blood tests. Up here, it doesn't really talk about a whole lot of different tests. I do want to point out an erythrocyte sedimentation rate. And when you hear that, or an ESR or a SED rate, I want you to think about inflammation, because that is indicative of the amount of inflammation that's going on in my body. So let's say a person comes in and they've said to me, I have a lot of pain in my joints. Of course, I automatically want to think arthritis of some reason, of some kind. And then do a blood test, and my SED rate comes back very high. Then I know there's a large amount of inflammation going on, and it kind of confirms my diagnosis of arthritis. I also want you to pay attention to, nothing really there. It talks about a C-reactive protein, but they're not very specific. But the SED rates, I want you to remember about the inflammation. The treatment is kind of in a two-step process. There's a couple of things we can do. When people have autoimmune disorders and they've lost any kind of body function, we can try to replace that body function with working with OT, PT, speech therapy, whatever it may be, or at least support the loss of that body function. If they've lost the ability to walk, maybe get them wheelchairs, rollators, whatever it may be. So we're trying to make the best of what we lost if we can't get it back, all right? But we do try to get it back. And then we've got an actual medication or therapies that try to halt the destructive process of what my body's doing to itself. So there's a couple ways to approach it. So I'm either going to try to get back what I've lost, or at least try to deal with what I've lost in some way, and take medications to try to stop the process of any further. Because remember, all autoimmune disease are trying to kill my own body's own cells. All right, we're going to talk about systemic lupus erythematosus, and it is a huge autoimmune disease that you'll hear about quite often. The body produces abnormal antibodies that attack target tissues instead of foreign agents. It's a little bit hard to diagnose as well. Some people just feel very bad, general malaise. They might see some redness on their skin. A lot of people end up with this butterfly rash. And that's where erythematosus actually comes in, because that word actually means patchy red congestion of the skin. So there's a few different kinds of lupus. There's the discord type, which affects just usually a specific area or specific organ. There's systemic, that affects the body as a whole. Does this even talk about this in here? Oh, actually it does. So it does say that usually in discord, that one organ that it affects is usually the skin, okay? And then we've got systemic that can affect anything in the body. And then we've got drug-induced forms. And my mom actually has a drug-induced form of systemic lupus, where she had a breast implant with silicone rupture, and now she has, it's changed her body's chemical makeup, and she actually has lupus. So I think typically in most situations I've seen the systemic type more often. I've had some patients with discord lupus, and the one lady I remember was absolutely, looked like she was raw from head to toe. And in any situation, we think that sunlight causes a problem. So these people, when they're out in the sun, they definitely need to have on sunblock. And we also see some correlation between UV lights and having exacerbations of lupus. Now, in most of your autoimmune problems, you're going to hear me use the word remissions and exacerbations. It's because not all the time are people in a constant state of turmoil. They'll have periods where they feel better and the disease process is not taking a big toll on their life, and that would be a remission period. And then they have periods where they do have an exacerbation, or a period of time where they're feeling a lot worse, okay? So that would be an exacerbation period, or what we might call a flare-up. Etiology and patho of SLE. Abnormal reaction against proteins found in the nucleus of the cells. And I do think that this talks about it a little bit. It does talk in your book about SLE waxing and waning, and that's those periods of remission and exacerbation with the flare-ups. It does talk about the sunlight in there, and exacerbation by drugs. The only drugs I really want you to remember when it comes to exacerbation, or a drug that's making the flare-ups worse, are your oral contraceptives and your sulfas and your penicillins, because those are very common drugs. Signs and symptoms, all body systems can be affected. Weakness is usually a hallmark of SLE, and that's hard because weakness is a hallmark of a lot of things. Your book does say that symptoms tend to come and go, and you might have painful or swollen joints, muscle pain, extreme fatigue, unexplained fever, red rash on the face, that butterfly rash, unusual loss of hair, sensitivity to the sun, mouth ulcers, poor appetite, weight loss, abnormal menses, edema, swollen glands, and a lot of those things sound like they could be other things. So when we start having patients come in with these problems, then we definitely want to be looking for that butterfly rash and doing tests for lupus. Again, those tests are not always definitive, and sometimes it takes a couple of times to test to actually figure it out. Sometimes they'll even do a test, they'll come back negative, and they'll say, oh, I don't believe that. I believe you're still positive for SLE. And that's what we're talking about on the next slide. No single test that confirms the diagnosis. There's lots of them. It says you must at least have 4 of the 11 clinical presentations or laboratory test results. So all those symptoms we just talked about combined with positive lab results, we have to have, there's a standard of 11 things that doctors check off, and you must meet 4 of them to have the diagnoses. Treatment, there's no cure. We take medications that target towards the symptoms and prevent exacerbations. One of those things is an anti-malarial drug. Let's see here, where is it at? Hydroxychloroquine is an anti-malarial drug that aids in long-term control of SLE, and malaria, of course, is a mosquito-borne illness, but they have found under scientific experiments that this medication prolongs and probably stops a lot of the problems with SLE, or at least the flare-ups. And because we see such a high level of inflammation in the body when we have a flare-up, NSAIDs and steroids are very, very good for those flare-up times because those are anti-inflammatories, okay? So when you have your flare-up periods, you may see people taking steroids, like glucocorticoids like prednisone, and your NSAIDs. I think that's good for that slide. Nursing management, caring for a patient with low immune response. I think we've covered that over and over and over, keeping them away from sick people, fresh fruits and flour. Anything that we could think of that might cause an infection, in the worst case scenario, we'd want to keep these people away from. We don't want them getting sick because sickness will cause them to go in an absolute flare of their lupus, okay? So if we have a antigen that enters the system for any reason, then my body goes through that major immune response, and I have inflammation on the whole body. All right, not a lot to cover on Hodgkin's and non-Hodgkin's. There is a difference between the two. When we say lymphoma, then we're talking about a cancer of the lymph system, okay? So these are both, Hodgkin's and non-Hodgkin's are both cancers of the lymph system. Hodgkin's we usually determine as a cancer of younger people just because we normally see it in people below 50. And it's highly curable if you catch it fast enough. So it's got a great cure rate, but you have to be able to catch it. Not saying people older than 50 can't get it, but typically you see it in younger people. For signs and symptoms, usually see abnormal swelling of lymph nodes above the diaphragm on occasion that can go below the diaphragm, like in the inguinal area or somewhere around there. But typically you'll see it in the neck, in the chest area. It'll be lymph nodes that swell up for no reason, like you typically see lymph nodes that will swell when you're sick or after you've been sick. This might be for no reason at all, and they swell up and they get bigger and bigger and bigger. And most that I have seen have been in the neck region, okay, around in this area. But they can be other places. And I do think your next slides talk about a little bit. Your next slide is a good clinical manifestations of Hodgkin's lymphoma. So we'll look at that next. Diagnosis and treatment. Diagnosis is usually done by looking for a very certain type of abnormal cell called a RS cell or a Reed-Steinberg cell. Your book does talk about those, I believe. Let me see. Yeah, it does. Under patho, it says the B cells in the immune system begin to develop atypical, which means non-normal cells. The abnormal Reed-Steinberg or RS cells have two unique features. They rapidly replicate, and they do not die off very quickly. All right? So anytime, all of my cells in my body, white or red cells, they all have a life cycle. They are made, they live out their days, and then they die, and then they're sloughed off somehow. Skin cells the same way, everything. And then we make new ones. But when I have an overgrowth of those cells, then I have things like tumors or, in this situation, cancerous material. So these B cells, instead of dying off when they should, they form this unusual cell, and it's called RS cells, I'm sure, by the person who founded it. But they replicate very fast, and then they live for a long time. So I have this abnormal growth of material, which ends up being this tumor for Hodgkin's lymphoma. Treatment's usually goes towards, okay, I'm also using, we got to go back to this, a diagnosis. So I'm doing biopsies to look for those cells. I'm doing CAT scans, I'm doing MRIs to see what it looks like inside. Those are the best things. Really, really pay attention to the RS cells. Going back to signs and symptoms, I wanted to touch a little bit more on that. We talked about the swelling, but your book also talks about profuse night sweats, unintentional weight loss. Here's a big one: abdominal fullness, and pruritus, which is itching. Okay. All right. So for treatment, the treatment really depends on the stage. Let's see here. Talking about chemotherapy in the book, also talking about involved node radiotherapy. Typically, INRT is delivered only to the affected areas of the body, so less damage occurs to the surrounding tissue. So some sort of radioactive therapy there, radiation towards the site itself. And I think that's about all you really need to know for treatment of Hodgkin's lymphoma. All right. is that we're going to diagnose it using CAT scan MRI and looking for those Reed-Steinberg cells, treating it with usually chemo and radiation of some sort. Remission is a word that we're going to use when we have the disease under control, and you'll hear that a lot in cancer patients. When we're no longer seeing those cells anymore, they're in a period of remission. But if we ever start to get sick again and we see those abnormal cells come back, that would be a period of relapse. Okay, slide 39 just go over that on your own. Just look at some things about clinical manifestations of Hodgkin's lymphoma, but the most important things about it are what we covered in the slides before. This is about staging of Hodgkin's lymphoma, and you can see the lymph nodes that are affected as we go all the way down to stage 4. You won't be tested on those. Typically, you're not the one diagnosing that either, but it is a cool little picture to look at. Non-Hodgkin's lymphoma on the next slide is much more aggressive. It does have a much higher death rate than does the Hodgkin's lymphoma. Let me find it in here. It's on page 236. It does say it's the 6th most common cancer in men and the 5th most common cancer in women. You know, and I forgot to tell you about that too. Going back to lupus, it is weird to think that women get more lupus than men, and then African American women have a higher rate of getting lupus than most, which is strange. But anyway, we'll go back to it. Non-Hodgkin's lymphoma, it says on page 239, NHL is similar to HL, but NHL is less predictable and tends to spread to other body sites more rapidly, as in Hodgkin's lymphoma, it may be just to a few lymph nodes itself. There's also an abnormal proliferation of defective B and T cells. Only biopsy of pathological lymph nodes and tumor tissues can provide a definitive diagnosis, so it's a little bit harder to diagnose as well. So we also read down through here and we see that we have bone marrow involvement in non-Hodgkin's. If we can get it treated earlier in like the first or second stages, it says we have a much better chance. That would be with any cancer. Other forms of NHL are more aggressive if treated with intensive chemotherapy. There's a survival cure rate of 67% in 5 years. That's not bad, not great, but not bad. Symptoms manifest early in the aggressive form, and with vigorous therapy, there is a potential for cure. The rate of cure is reduced if NHL is diagnosed in the late phase. Yeah. Signs and symptoms, here's a big one to remember. Unlike HL, NHL typically shows up in one node, then one or more nodes are skipped, and then another node is affected. This is called non-continuous. NHL usually manifests as unilateral, which means one side, painless enlargement of lymph nodes that may progress to generalized painless lymphadenopathy. NHL tumors can occur in the brain, respiratory system, spleen, GI tract, many other places. Many. I'm usually going to see fever, chills, drenching night sweats, unexplained weight loss, cough, dyspnea, chest pain, vomiting, sense of fullness in the abdomen, and constipation. A lot going on in non-Hodgkin's. For diagnosis and treatment, the diagnosis, of course, depends on what stage they're actually in. If they're further staged along, then the diagnosis will be much more grim. Staging, we don't need to worry about that, but DESA staging considers the number and location of the affected lymph nodes. And you can see that in the slide before. See how many more lymph nodes were affected, and that was a more progressed stage. We're, of course, going to do the same thing. We're going to use CAT scans, MRI, and biopsies to determine. We also may do some bone marrow biopsies, fine needle aspirations of the lymph nodes themselves to try to figure out what's going on. And then treatment, we're usually going to go back to, there's different drugs to take too, but we also go back to chemo in here as well, and radiation therapy. Actually, I think it talks about more radiation therapy than chemo in this one, so certain drugs and radiation therapy. When you go through this non-Hodgkin's lymphoma, read through it, but again, what I'm touching on is the most important parts. Primary lymphedema. Lymphedema is swelling of the lymph system of the lymph nodes. Primary lymphedema is something that is not caused by another problem itself. It's usually inherited or it's congenital, means I was born with it. And you usually see that in the lower extremities. So if you Google primary lymphedema, you may see someone who has this ginormous left leg and then a normal right leg because it only happened in that one leg. It's very strange. Sometimes they're very, very huge. But if it says primary, that means it wasn't caused by something else. This also says it chiefly affects females and most often becomes apparent during the middle teens to early 20s. So in this situation, then for some reason I've got too much lymph. It's probably backed up because my lymph system didn't grow appropriately when I was in utero. But for some reason, it's not draining. There's, tons and tons of those little canals in the lymph system draining lymph. And for some reason, in this one particular area, it cannot drain appropriately. So I have this huge, massive edema. Secondary lymphedema is acquired. That means it's caused from another reason. This says it's caused by an obstruction, maybe by trauma to the lymph vessel itself or the nodes. A huge talking point here is a mastectomy. A mastectomy is when I take breast tissue and most times lymph nodes from the axilla out because of cancerous material. When I take pieces of the lymph system out, then they're just kind of cut off, all right? So where they used to flow, there's no way for them to flow anymore. I can get a backup, okay? So that would be one way to obstruct. It says also extensive soft tissue injury that causes scar formation. Of course, if I've got scarring in the area where those vessels used to be, then of course the lymph can't flow, all right? So both of those things can cause, it also says parasites entering the lymph channels. I've never seen that before. I don't think I've ever heard of that before until now, but I suppose it can happen. But for some reason, something's happened in my life and my lymph cannot drain appropriately. Now for mastectomies, you want to make sure because they don't have good lymph circulation on that side anyway, there'll be no blood pressures and no IV sticks, no needle sticks at all. Because if I mess it up even more, I can have massive amounts of swelling, and I don't want to do that to anyone. If anyone has a double mastectomy, we may have to get blood and blood pressures in the legs. These people should have signs in the room, so if lab comes in or your CNAs come in, they know not to do the blood pressures in those arms. More on secondary lymphedema. Patients may present with a variety of symptoms, including restricted range of motion. Of course, if you've got large amounts of edema in one appendage, then it's going to be hard to move. A heavy feeling because it's full of fluid. Aching discomfort, that's all the fluid pushing on your nerve endings. Recurrent infections, because when I have all that edema present, it's going to push on my cardiovascular system, and I need my blood to flow correctly to get nutrients to the tissues so I can heal. So when I have all this edema, my blood cannot get to the tissues to help fight infections, so I have recurrent infections. And then I have thick, hard skin just because it's so used to breaking open and growing back and things of that matter. Regardless of what causes the lymphedema, treatment goals are to minimize the impact of the disease on the individual. So teaching them how to live with it, teaching them how to prevent infections, taking care of the skin on that affected area, very, very important. Fibromyalgia is the next one, and fibromyalgia is a very odd disease. It's a disorder that many people didn't believe in for a lot of years because people would just present with massive amounts of what we would call muscle pain, and there was no way to determine what it was. And we were doing tests and nothing was coming back positive. But now people believe in fibromyalgia, and it happens a lot. And I think it says it affects women 10 times more than men, and seen in younger women 25 to 60 years of age. This causes chronic systemic pain and multiple symptoms not caused by any other source, and that's why a lot of people ended up, when we couldn't figure out what was wrong, people were getting the diagnosis of fibromyalgia. But now we do believe in it, or at least most people do. Things that can make fibromyalgia worse are stressors such as infection, trauma, drugs, hormonal influences, psychological distress. But you have to remember that we consider fibromyalgia autoimmune, and that any of these things can cause any autoimmune disorder to flare up. Anytime my body goes on high alert because of trauma or hormones or infection, anytime the alert system goes off, if I have an autoimmune disorder, thousands of alarm systems go off and my body overreacts to it and starts killing good cells. Fibromyalgia continued. The most common feature of this disorder is musculoskeletal pain. Definitely remember these two words, hyperalgesia. That means that I have a huge pain response to something that should be minimally painful. So I might be able to very slightly pinch you and it would just be ow for most people, but it might hurt drastically for this person with fibromyalgia. Also allodynia, which is painful response to non-painful stimuli. I might be able to very push in on your arm. For most people, they would just feel pressure that might cause an abnormal amount of pain for these people with fibromyalgia. These are very indicative of fibromyalgia, and you should remember them. This is showing some tender points for people that typically have fibromyalgia. The next slide, slide 48, is symptoms. Tension or migraine headaches are common with people with fibromyalgia. Lots of jaw and facial tenderness. Insomnia, vertigo, which means I'm very dizzy, I can't get my balance. Difficulty concentration, memory recall, which is very strange. And performing simple mental tasks. This is strange for a progressive disease that causes muscle pain, so things that will probably stick out in your head. And of course, anxiety and depression, and that occurs with lots of people with many different kinds of autoimmune problems. Next slide, symptoms continue. Numbness or tingling in the face, arms, hands, or feet. That is a huge problem. We call that neuralgia. That's a huge problem with people with fibromyalgia. Sensation of swelling, but they're not actually swelling. It feels like you're swelling, but it's because there's cellular damage happening on the inside at the muscle. Abdominal pain, bloating, nausea, constipation with sometimes diarrhea, and dysmenorrhea, which is painful periods. Remember, some people don't have painful periods, but these people have pretty painful periods. Symptoms, again, increased in urinary urgency or frequency, sensitivity to one or more of the following things: odors, noise, bright lights, medication, certain foods. You usually see those in all people who have migraine headaches. So if you have these people in the hospital, you want to reduce any of this that might bother them. And cold is another thing that causes people to have a flare-up of fibromyalgia. Symptom relief of fibromyalgia, first, is antidepressants. Antidepressants work a couple of ways. Antidepressants work at pain sites to reduce pain. We use them sometimes as pain relief. Of course, they're not the greatest of pain relief, but for these people, they are, because they work at the nerve sites. Plus, we use it for the anxiety and depression. NSAIDs, because we're going, we said with all these problems, we're having large amounts of inflammation, then we're going to use these NSAIDs, and they're much better than the narcotics. Additional treatment that can help people with recurrent problems: exercise, massage therapy, which you have to be careful of, because if these people have that weird pain sensation, they can't do massage. Guided imagery, definitely dietary changes, eating healthier can prevent a lot of these flare-ups, and maybe even a referral to a mental health provider. Nursing responsibilities. Your responsibilities, of course, in all of these are to get a detailed assessment of the symptoms and the history, documenting what the patient says makes the pain worse, what makes the pain better. That can tell us a lot about fibromyalgia. If somebody says they have those weird pain sensations or things are hurting when they normally shouldn't, that's a big key to be looking for fibromyalgia. Allergies, which are one of my favorite things to talk about. An allergy is an abnormal response to certain substances. And allergies are really cool to think about. An allergy, for most of us, if we come in contact with a peanut, then we're fine. But for some reason, some people, when they have a peanut for the first time, their body decides they don't really like it, and they're going to make antibodies to it. So remember when we were talking about B cells, and how when we have certain B cells that have certain antibodies on their surface, like they're wearing a little antibody hat, and they're looking for very specific antigens. This is how it starts, is I'm exposed to something for the first time, and forever, hopefully, I'll keep making B cells and T cells that have that specific antibody to find that antigen. Now, an allergy is unwanted, though, okay? It's a response that I don't want. So in this person who's ate the peanut the first time, their body doesn't really do anything, okay? I don't really see a lot of outward signs, but inside lots of things are happening. My body decides it doesn't like the peanut, so it starts making antibodies to it. And so from now on, when I ingest a peanut, my B cells, some of them, are already carrying the little hat on the outside that says, hey, I'm an antibody that I'm going to find anytime you eat a peanut, I'm going to cause this exaggerated response. So if I eat a peanut the second time, my body remembers I hated that. All right, so I'm going to go back and I am going to cause just chaos, okay? And of course, allergic reactions can vary from minimal to anaphylaxis, which would be swelling of the airways. But anyway, it's abnormal. So I usually don't see a response the first time because my body's making those antibodies. but the second time is where I see a problem. Allergens can enter the body in several different ways. Of course, they can. I can get a bee sting. So anything that breaks my skin, I can inhale allergens. I can eat allergens. They can go directly into my bloodstream by IV. I can ingest them by medications. I can be allergic by food. There's lots of things people end up being allergic to. Allergies continued. We talked about the etiology and the patho already. Signs and symptoms, of course, can be as slight as just a little bit of an itch, all the way up to your airways closing, and we'll talk about anaphylaxis in a minute. Some allergies include GI distress, but sometimes the doctors will just say that you're sensitive to the drugs. It depends on how bad they are. For diagnosis of allergies, it talks about a RAST test, and that is something that we don't see a whole lot. And I know that it does talk about a RAST test in here. Read over that a little bit, but more about the skin testing than anything. And we talked about the skin testing earlier, where they take all the little plastic scrapey things on your back, and they put all the little different allergens in and cause a little scratch. And then they monitor how big that inflammation or that swelling gets, and they determine if you're allergic to it. Now, in some situations, because they only put such a tiny, small amount of that allergen on that scratch test, if you have a overreaction on your back, they may actually give you little intradermal injections of that same allergen that's in a higher dose to see if you're allergic to it. Okay, so you might, when you go in for skin testing, you might get some intradermals as well. Next slide, drug allergies, food allergies. Of course, we're always asking those upon admission. Any kind of foods, any kind of drugs, whether it be prescription, over the counter. I want to know if they're allergic to anything. Anything. And that is every time they're admitted. It doesn't matter if I saw them 2 weeks ago. When they come back in for admission, I have to retouch that. Treatment. Treatment, of course, we have it. We'll tell them to stay away from the allergy. If you're allergic to peanuts, don't eat a peanut, of course. Drug therapy. We have things like Benadryl. We have second-generation antihistamines like Zyrtec and Claritin. And what's really weird about your body and allergens is there's this type of cell that lives in my body all the time. It's supposed to be there. It's in my tissues, and it's called mast cells. And mast cells are what produce histamines, and histamines are what make me itch. Okay? So if I take a Benadryl, which is an antihistamine, then it stops me from itching. It blocks the histamine from getting to its receptor site. So it blocks the message from its mailbox, okay? The antihistamine gets right in between. This message can't get to the mailbox, so I'm not itching, all right? So I can use things like that because when I'm having an allergic response, I'm having drastic amounts of histamine. My mast cells are releasing so much histamine that I have this allergic response. So I can take things like that. If I have I could take a Benadryl, or if I have seasonal allergies, I can take a Zyrtec or whatever it may be, and it can combat that. I can also desensitize you to allergens, and that's getting allergy injections weekly, usually weekly, and it's usually for years and years and years. So after you have your scratch test done, the doctor will determine everything that you're allergic to, and then the pharmacy will make vials of all your allergens put together, okay? And then depending on it, could be more than that. When I had my allergy testing last time, I was allergic to so much, they had to make 3 vials. And I'm not taking them right now, and you can see I'm sick. But what they do is they subject you weekly to very tiny amounts of each allergen, so over time you get desensitized to them. And again, most of the time that's weekly injections for years and years and years. Sometimes they work and you can come off of them forever. Sometimes they work and you can come off of them for years. And sometimes you never desensitize to them. And then sometimes some people are so sensitive to that allergen, just getting the allergy shot sends them into an allergic reaction. The next one is hypersensitivity. This is what we've been talking about the whole time. This is what we refer to as allergic reactions. Your body's excessive response to normally harmless substances. All right. Under etiology and pathophysiology, it talks about a type 1 hypersensitivity, which is immediate hypersensitivity. And these are related to your mast cells. And then we have a type 2 that's a delayed reaction, and that's involving your T cells. So we just talked a little bit earlier about the mast cells, and mast cells, again, are something that is in your body. Everyone has them. They're everywhere, and they're carrying a couple of different things, but what we want to talk about here is histamine. And then when I have this hypersensitivity, then all these mast cells are just running around everywhere. Massive amounts of mast cells just releasing histamine, all right? When in most situations, I should only release a little bit, all right? But now they're just releasing tons of histamines. Type 2 sensitivity is a little bit more delayed, and that comes from my T cells. And remember, I've got T cells that come out that remember that I've been exposed to things before as well. This is on page, I don't know. Let me find it for you real quick. Well, I don't know where it's at. But somewhere in the book it talks about both of these. I'm pretty sure it wouldn't be on the slides. But what I usually see, and it's very fast, when I have someone who ingests a peanut and they get sick pretty fast, that's going to be all those mast cells releasing all that histamine. Diagnosis, we've talked about these already in the previous slide. Your RAS test, which is looking for the allergens via blood sample, and then your skin testing, those scratch tests we were talking about. Here's some things in primary allergic conditions that can happen during an allergy attack. Anaphylaxis being the worst. Anaphylaxis we're going to have a whole slide about in just a moment. Angioedema is swelling around the eyes. If my eyes are swelling around them, then I am in grave danger. I want to make sure I'm doing something fast. If my eyes are already swelling, it probably won't be long until my airway swells. Asthma, of course, people with asthma are more prone, actually people who have allergies are more prone to have asthma. In asthma, I have narrowing of the airways, and that could be because I've got constriction of the airways or because I've got mucus blocking the airway. But in this situation, it's usually because my airway's closing up, okay? Now, if I hear a wheeze, then I know the airway has constricted. But if I stop hearing the wheeze, then I'm in big trouble. If I've heard one, then I stop hearing it. I've not done anything. That means there's no air moving. So I'm in bad danger, probably a trach. So if I've got somebody, and I'll get ahead of myself. We'll talk about that in a minute. Atopic dermatitis, of course, is eczema, rashy, itchy skin. A lot of kids have this when they come in contact with grasses and stuff. Sometimes we give oatmeal baths for them. Food or allergy intolerance. Sometimes food like peanuts causes us to have a big allergy, and sometimes when we have certain foods, our body just doesn't like it. Like we might get diarrhea or upset stomach, and that would be more of an intolerance. Perennial allergic rhinitis or sinusitis. Perennial means when certain things bloom. I'm pretty sure that's what the book says it is. I don't know. I didn't read it, but that part in it. But I'm pretty sure that perennial means when certain things are blooming, and then I might get a runny nose and a little bit of a stuffy nose. But if it's runny like that and my sinuses are not involved, it's just rhinitis. But if it goes up into my sinus cavities, okay, all those 4 sets you have, then I'm going to consider it sinusitis. And sinusitis is usually the big term for a sinus infection, like I have now. Seasonal allergic reactions can also called rhinoconjunctivitis, and that would be what we kind of see as hay fever. And that's when I have all this snotty, runny nose, and I've got itchy, watery, red eyes. And urticaria is a red, itchy patch of skin. There's 4 broad categories of allergens. Contactants, like if I touched those kids who roll around in the grass and they get contact dermatitis or eczema. And then I've got ingestants, things that I actually ingest, like the peanut or like medications. Inhalants could be if I go outside and inhale pollen. And then injectables could be anything from a medication that's injected into my vein or even a bee sting. Slide 61. General data collection. I'll let you read through this. We want to make sure this is important. Pay attention to this slide. Asking all this history because we want to try to pinpoint exactly what the allergen is. Have they changed anything? Was there anything new? What happened before this happened? Has this happened before? Really pay attention to this slide, especially about the wheezing and the shortness of breath, because we know that could be a pretty big allergen then. Next slide is assessment of the skin. Do they have any burning, itching, dryness, inflammations, any rashes? Are their eyes red, tearing? History of styes, where little areas that look like kind of like little tiny pimples of right at the root of the eyelash? Is there any discoloration below the eyes? They call those allergic shiners. We usually get that because we rub our eyes a lot, and excessive blinking because those allergic shiners. Next one is the nose. History of nose twitching, which, see, I do that. I always have nose problems, but I think some people just have tics. Definitely with stuffiness, recurrent nosebleeds. Sometimes things get very agitated and they bleed, and sometimes we use nose sprays that dry them out, but definitely want to know about nosebleeds. And sneezing. The allergic salute is this. When you push your nose up and you get this little ridge across your nose right here. I think I even have one. Oh my gosh, I do. You see it? Yep. And that's for people who are really kind of rubbing their nose and blowing their nose a lot because of allergies. Nasal polyps are a big symptom. Nasal polyps are overgrowths of tissue inside the sinuses that make it hard for the sinuses to drain. Those are very typical for people with lots of allergens. And then sometimes they have this nasal voice, which I've got going on right now. More assessment, mouth and throat. If they're mouth breathing, then we know their nose is probably stopped up. If they're continually clearing their throat, they've probably got sinus drainage that would also cause redness. If their lips and tongue are swelling, you're in an emergency. Okay, that means that their airway's about to swell. Ears. Have they had any hearing loss? That could be a buildup of stuff in the ear canal. That could actually be damage to the eustachian tubes that connect into your sinuses. And if there any drainage from the ears. Drainage from the ears is never a good thing. Neck, do I feel any lymph nodes in there? Did anything look different? If I feel lymph nodes that are swollen, I know things are going on in there and I'm fighting something. Next page is nursing implications. I'll just let you read over this slide. Let's see. Making sure people, I think we've talked most about this anyway. I've let this video go on for way too long. The next slide is anaphylactic reactions and shock. We're not going to cover shock, but we're going to talk about anaphylactic reaction next one. Now, when you see IgE or IgM or IgA or IgG, any of those immunoglobulins, remember those are antibodies, all right? Those are the things that my body makes to fight off an antigen, and an allergen would be an antigen, all right? So don't have to worry about learning the different immunoglobulins right now. Just know that those are antibodies. Let's see here. I want to skip the next one. Go to effects of anaphylaxis on slide 68, which is a diagram, a picture. And it's really great to help you understand what happens in anaphylaxis. At the top, it says that you see my mast cell there, and remember my mast cell is going to release histamines. And at that point, I've got all these little antigens, and you see that antigen and that antibody that's very specific to that antigen, they attach to each other. And that antibody is sitting right on top of that mast cell. So here comes my antigen, and there's this antibody that says, oh, that's my antigen. I've seen that antigen before, and they collide. Okay, they stick. Now, an antigen for one thing wouldn't combine with every antibody, only the one that it's meant for. All right, it's like a lock and key. So my peanut allergy antigen would not connect with my chickenpox antibody. All right, only the ones they're meant for. And so when that happens, it says antigens bind with the IgE antibodies. Remember, immunoglobulins are antibodies. And the mast cell releases large amounts of histamine into general circulation. And we see there, it goes to my cardiovascular system, my skin, and my lungs. When it hits my skin, I have vasodilation. So I've got all, my vessels open up really wide. And it says I have increased capillary permeability, which means that I'll have excess fluid going out into the tissues. In my skin, my nerve endings get irritated and I get itchy and scratchy. And then in my lungs, I have constriction of my bronchioles and I release mucus. So not only is my bronchioles getting smaller, but they're full of mucus as well. Under cardiovascular system, it says from there, my blood pressure gets weak because I've just got this my vessels have gotten huge, and it wasn't because I had so much blood to pump, it was just because they got big. And then, of course, my nerve endings, we had itching, and then my airway. All these things lead to, the blood part and the oxygen part lead all the way down to severe oxygen deficit to the brain, so we can lose a lot. Treatment of anaphylaxis, we need to make sure we have a patent airway. That's our biggest concern. If somebody's airway looks like they're tightening up, and we don't have any medication, or the medication's not working, and we need to make sure that they get intubated. And if they've already closed up, we can't get a tube down, they may have to be trached. We need to make sure they have supplementary oxygen, because we're worried about enough oxygen getting to the brain because everything else that's happening in here with the cardiovascular system as well. So we want to throw on some oxygen, supplementary oxygen to them. If they're trached, they'll be going to their trach. If they're intubated, on their ET tube. If they still have somewhat of an airway, and make sure you've got it, probably a mask. If they've got anaphylaxis, we want to give epinephrine. We would not want to give Benadryl in the terms of anaphylaxis, because Benadryl takes time to work. Most Benadryl is oral. We can give it IV, but it's not going to be like epinephrine, like an EpiPen. That's going to be super fast. After we get the epinephrine in first, though, we can give the Benadryl, the antihistamine, and that usually goes hand in hand, but the epi always comes first in the case of anaphylaxis. Institute measures to prevent control of shock and provide psychosocial support during the course of treatment. It's very scary, not only for the patient, but their family as well. All right, that was a lot to cover, and that's like 7 hours of lecture and just a couple of videos. So we'll talk about what you guys have listened to so far and post-conference today, and then we can talk about it again tomorrow as well. So in the morning, we'll meet for roll call again, and then I'll have another video for you guys to watch for Pharm. Bye.